So this is a live recorded case that you'll see. The faces and voices that you'll see here are myself, Ebbs, and Stephen Broughton, our structural fellow. This is an 89-year-old male who presented to our multidisciplinary valve clinic with a history of HFpEF, paroxysmal atrial fibrillation, hypertension, chronic kidney disease, objective frailty, clearly a high-risk patient overall, known severe aortic stenosis, followed by one of our HVI cardiologists, as well as a primary care doc within the system. Very active guy, now with dyspnea on exertion, walking the stairs, not able to play golf as he would like to, referred for TAVR evaluation. STS 3.23%. His baseline creatinine is 2. He's frailty with the use of, has objective frailty with use of an assistive device for ambulation, and has a pulmonary artery systolic pressure of 73 on his echocardiogram. His echocardiogram, it's real deal severe aortic stenosis, stage D disease, 4.143, and he's in atrial fibrillation at that time. His LVOT velocity was slightly low. If we look at his annular dimensions and measurements, on the left you see the annular perimeter, and on the right you see the annular max and min, the min being about 24, and the perimeter here being about 79, 80 millimeters. His sinuses of Valsalva are quite large to accommodate a self-expanding valve. And you can see on the right side his access. There's a little calcification at the entry point at the right common femoral artery, but the access is overall doable from an iliofemoral standpoint. Baseline EKG, right bundle branch block, left anterior fascicular block, highest risk for development of a transcatheter valve-related pacemaker.
So let's stop right there. Let's go back a slide. So what would you quote this risk of pacemaker in this particular patient?
So this
Let's start with a standard 89-year-old. What are you going to tell that patient?
So the standard 89-year-old institutionally, the pacemaker rate in all comers would be 8%. If somebody has a right bundle branch block, that number goes up substantially. Right bundle branch block, left anterior fascicular block, we're looking at a 50-50 coin flip for needing a pacemaker.
Hemel, you're on the line. What do you think?
Yeah, no, I mean, this is great.
And don't make us look too bad, okay?
No, never. Kudos to you for presenting this case. This is like slam dunk commercial case. This is what we deal with on a daily basis. These are some of the challenges that we work through. This antecedent conduction pattern, I mean, so common in our octo and nonagenarians. And so planning with our electrophysiology colleagues exactly who gets a pacemaker versus not, I think is the first question, right? Now you're coming into this case, this patient has high-risk features. How do you manage this appropriately so that your rate of conduction disturbance is less? And we'll talk about the implantation technique and whatnot that you go about with this case. But I think, like, you know, all comers coming in, the pacemaker rates have definitely fallen, obviously, as Amber referred to during her excellent talk. So like Dustin said, less than 10% risk in someone who has a normal EKG with a self-expanding valve. But we're going much higher, right? And so I would say something around the ballpark of 35% in this particular conduction pattern. And so something to be very cognizant about with our peri-procedural and post-procedural management.
Now, would you change strategy and say, well, maybe if I put a balloon expanding valve in, there'll be a lower pacemaker rate? Do you think that's worth it? I mean, some people
I don't know if you can say that, right? So, like, I mean, if we look at the TVT registry data, what it's shaping out to be is that self-expanding valves, when deployed with the cusp overlap technique with the newer technology, has pacemaker rates that are probably below that of balloon expandable valves in the immediate term follow-up. Now, that may not be that hospitalization, but within the first 30 days. And I can tell you anecdotally at our center, we've seen a lot more late onset conduction disturbances with balloon expandable valves than we have self-expanding, particularly in this patient population. So these are the patients to handle with kid gloves. And if you're putting in a balloon expandable and you don't get any conduction disturbance off the bat, don't think you're off the hook. Yeah. And so we can talk about long-term monitoring strategies.
Great point.
I would totally agree with that, Hemel. And unfortunately, the ones that we've seen are the ones that we've discharged and have come back with syncope. This is not the,
exactly.
You know, they're in the hospital 2 days later and they have this problem with balloon expandables. So, so our case, we've chosen a 29 Navitor valve based on our annular anatomy here, and our case plan 29 Navitor MAC anesthesia. We've got a left radial A line and peripheral IV, right common femoral artery TAVR access. We are still using our life preservers with our 2 ProGlide closure technique. The left common femoral pigtail and temporary pacemaker catheter, we're going to predilate with a 24 millimeter Z-Med, and we're looking at 2 to 4 millimeters here with this Navitor based on right bundle, left anterior fascicular block.
Okay. So Catlin, as you look through this, you know, a couple of things. Obviously, I think, tell us a little bit about your MAC versus general anesthesia experience over time.
Well, the general anesthesia, now we reserve it only for cases for alternate access where we convert to general anesthesia when something happens in the case, but most commonly is MAC. It's essentially 90% MAC nowadays. These patients, you know, they're elderly. They don't do well with general anesthesia. They do, you know, better with MAC than with general anesthesia. I mean, we've seen this. We've heard this from Europe about doing this with conscious sedation, which sometimes is a little rough for these patients. So I think MAC is providing the sweet spot for this procedure.
Yeah. Now, obviously, you know, this patient had a left femoral diagnostic pigtail catheter, right? So Amber and Conrad, I mean, do you think worthwhile just going radial for diagnostic purposes? Obviously, as folks have moved away from cerebral protection.
It's not unreasonable, but I think you know, isolating the non-coronary cusp with the pigtail can sometimes be challenging going from the radial. So typically, we still kind of default to going through the femoral, and we haven't really seen significant adverse vascular complications from doing that.
Hemel, what have you been doing? I assume your cerebral protection rate has gone down, or use, I should
Yeah,
say.
tremendously. I mean, we only use it really for basilica cases now. So I will say that, you know, in general, like Amber said, it's a left femoral access for a pig. We've developed a lot of efficiency surrounding that. Obviously, the patient can then recover down in the post-cath lab recovery area, get their sheath pulled there, that sort of thing. So I think the efficiency works out just fine.
Great.
Presentation slides here at this point and just put the main screen case there if you would.
Yeah, James, if you can do that, please. All right, Dustin, you want to walk through the rest of the case, and I'll pause for some comments.
Yeah, sure. So we've put a 12-French sheath in on the right side after putting our per closes in and setting those aside. So that's prepped and ready for us to go. We're putting our temporary pacemaker up now. We're still using balloon tip temporary pacemaker catheters from the groin. We've not had the elevated perforation rate that has been described in the literature for some of these happen locally, so we've gotten away from that. And on the right-hand side, you see fluoroscopically, we've got a pigtail catheter that comes from that left femoral sheath up into the non-coronary cusp.
So let me stop you right there. So some operators may argue, particularly from Europe, well, you know, this patient's high risk, will need a pacemaker. You might as well put it right IG or not do anything at all. And then some folks talk about deploying these without pacing. What do you guys think? Worth it, not worth it?
I think from a self-expanding valve perspective, in particular, the pacing off the wire doesn't help us much here because we're not really using the wire, and often, as you'll see when we deploy this valve, the wire's not even in the ventricle during deployment. We do think there's very little downside to rapid pacing these patients from a hemodynamic perspective, and the valve stability that's added is certainly helpful. So that we still do this.
Hemel, what do you think? Anything's changed in that category for you?
We LV wire pace. Obviously, the vast majority of our patients, in this case, probably LV wire pace. I think it's personal preference. But to Dustin's point, I don't think there's a downside in rapid pacing most of these individuals. And to the point of valve stability while you're deploying, I think it's absolutely beneficial. So I'd recommend rapid pacing the majority of these patients.
Dustin, walk us through what we're doing here.
Sure. The first point that I would make here with this platform in particular, we really, with earlier generation self-expanding devices, which are going to give us better hemodynamic performance, had a lot of trouble with horizontal root anatomy. It was quite a challenging implant. So when we see these patients with horizontal root anatomy, as exemplified by where that pigtail is, we worry a little. This is just a 5-French AL1 catheter and an 035 straight wire, and we're trial and error crossing the wire across the ventricle.
Trial and error. I thought it was very precise.
It's not quite precise. The other interesting thing that you notice here, and I want to point this out because I'm seeing it now and I remember this case specifically, one of the things that you see here, so this is a patient with pulmonary hypertension who's got a bit of a dilated right ventricle, and if you watch his hemodynamics in the bottom left of the screen, you start to see that his STs are not normal here, even in the presence of a bundle. There may be some uptrending STs and ST elevations that we're looking at, and I'm not sure that I noticed this at the time of. The other thing you're seeing is we've got a wire in the ventricle, and we've got a lot of non-sustained ventricular ectopy here, obviously, and our aortic pressure line has taken a hit because of that. And the reason we really wanted to show this in full disclosure is we want to show what happens in the operating room with these cases. We also want to show what we get away with in the operating room with these cases. So, somebody that we would be really worried about rapid pacing, at the same time, we've got, significant non-sustained ventricular tachyarrhythmia here, and we've had no problem. So we've now exchanged for a stiff wire in the ventricle, and as that's done with all self-expanding valves, we perform a pre-deployment balloon valvuloplasty. This is to allow our self-expanding valve to go in and have an easier ability of expanding and contacting the annulus. So under rapid pacing, as you can see on the hemodynamic tracing, we're trying to eliminate the pulsatility, and then we perform pre-deployment valvuloplasty here.
Amber, Catlin, Hamel, Conrad, what do you guys think? BAV for all these patients, self-expanding? Yes,
I think
no?
you have to. You have to. This is a very decent calcium burden. You are really aiming for a very precise level of depth here. You tend not to want to post-dilate for a couple of different reasons, but I think the most important one here is you don't know how much foreshortening you're going to get on that valve frame if you don't pre-dilate, and fairly aggressively. Obviously, our practices use non-compliant balloon. You guys are using a Z-Med. Regardless, pre-dilation absolutely key to really get that depth that you want on that implant.
And don't pay attention to the wire, Hamel.
So Hamel,
I told you I'm not going to say anything bad at all.
question for you. So how do you size your balloon? We go usually by minimal diameter. Are you getting more aggressive with that now, or?
Yeah, absolutely. So Catalin, we're going mean for most of our patients. Now, you got a little bit of a chunk of protruding calcium here, and so maybe I'd be more inclined to min +1 on this one. But I think the vast majority of our cases, we're doing mean annulus versus LVOT, whatever's the lesser of the two. That's the true balloon size that we're going to pick. And we've obviously had some good success with that approach.
And is it more aggressive with the Portic or the Navitor than the Evolut, do you think? Or do you think you need to be more aggressive with the Navitor?
Simple, man. So basically, I try to, broad brushstrokes paint my pre-dilation strategy for all self-expanding platforms. And so I haven't noticed a difference. If anything, the benefit that I've noticed with Navitor is just that annular stabilization, because the radial force is really distributed very well up the length of the valve frame, and the cylindrical shape versus the flaring out of the Evolut. So I've noticed a lot more stability on tab release as a result of the Navitor, but honestly has not changed my pre-dilation practice.
And for those watching, obviously we're rapid pacing as we do this, hence you see a flat line on there. So.
The other point that I want to make here, if you look at the top left-hand screen at our hands, light gloves is me, dark gloves is Ebes. The patients and the primary care docs often say, well, who actually does this thing? And I just want to demonstrate that there are two integral sets of hands on this thing, one positioning from a depth perspective and one actually deploying the valve. And that's a common question that we get, so that's the only reason I bring that up.
The gloves are supposed to match my olive tan skin, So tell us a little bit about the deployment mechanism for this.
So this
Justin,
is
what
the
advantages
FlexNav
are.
system with the Navitor valve, and what we're doing here is we have the pigtail in that non-coronary cusp. We're injecting contrast to get us to the right level, and then you can see the dot on the delivery catheter, which we're trying to pull back and position directly at the nadir of the sinus and the nadir of that pigtail. We go to about 80% by turning that wheel that you see in the top left-hand side of the screen. There's a hard lock out there, and we do this again under rapid pacing with low aortic pressures. Once we reach that hard lockout, we will wean the pacemaker. We will not just turn it off. A lot of these patients with right bundle branch block will have conduction delay when we stop pacing, and we may need to temporarily pace them. So we will wean that pacemaker. And then we will take a look at our valve, and we'll take a picture here in this view, which is our traditional cusp overlap view. We'll take a view in the LAO projection to see where we are. So we've taken our cusp overlap view. We're going to scroll over to the LAO view. Here we're looking for the non-coronary leaflet of the valve and position the frame relative to that. And then as we scroll over to the left, we want to see where the position is on the left sinus. We want to make sure that we have annular contact there, and we want to make sure that we're 1 to 2 millimeters below that, ideally.
So what do you think, Catlin?
Before I answer that, are we broadcasting this, or are we seeing Hamel's live?
No, this is being broadcast, right, James? Everything's being broadcast. This is, yeah.
All right, sorry. Yeah, so this is a technique that the cusp overlap technique with some modifications that Hamel has been instrumental in developing. And the concept here is that when you come with the self-expanding valves, the non-coronary cusp is the lowest point. So if you secure that point, almost 100% of the time you're going to be below the valve everywhere else. And the second thing is that the higher you are, the less likely you are to have a conduction problem. And that's why we were talking about, avoiding conduction issues with this technique. It's slightly different for the Navitor valve. I think this valve rotates differently upon deployment than the Evolut valve, in my experience. And this is why we kind of had to adjust a little bit the technique and make sure that we're sitting below the left cusp as well. Hence the additional view that we take. But it's been working well, and I think it's becoming sort of the standard way of implanting this valve nowadays.
Amber, what did you think of that first initial placement? Like it, hate it?
I think that it's useful to wean the pacemaker to figure out. We already knew that we had a high rate of pacemaker risk going into this case with the baseline conduction abnormalities. It's helpful to kind of wean the pacemaker, see where we are from a conduction standpoint. I think it's possible to implant the valve at a little higher depth, but certainly not unreasonable.
I think you're being too kind. I think Hemel is nodding vigorously there. So we knew that he was watching and he's going to be commenting on this. So we decided to recapture and redeploy here, right? So what do we think of this, Hemel?
Very nice. No, I mean, and this is done, just expertly, right? So the great thing about this view and the great thing about the nature of the self-expanding platform, the recapturability, is the fact that you can adjust like this. And this is a beautiful example of that. And so to Catalin's point, you definitely want to make sure that you caught the left cusp. We have noticed that with Navitor as well. The valve does release a little bit different. It does tend to stabilize a little bit more in the annular plane and not shift as much because the radial force isn't as centralized down there in the annular plane. And so really catching the left cusp is really the shallowest that you need to be, right, or can be. But other than that, on the non-side, you're free to do whatever you'd like. And so with sub-millimeter precision in the cusp overlap technique, lifting this thing up a few millimeters is to your advantage for a couple of different reasons. The conduction disturbance issue, which we've mentioned, but also the fact that hemodynamics tend to improve with this platform the higher you implant it. At least anecdotally, that's been our experience. But what do you think, Yves? I mean, have you noticed that, the higher implantations with this valve?
Yeah, honestly, we've been so pleased with the hemodynamics, and Amber showed you some of the data we presented at TVT last year and CRT this year, which is, it doesn't matter perhaps it does. I think there's probably more arguments to make about durability and the way the valves function and perhaps preventing halt and ham with appropriate deployment than the hemodynamics. But I agree with you. I mean, I think you catch on to a good spot. I think if you're high and nice, it does make a difference. The advantage is, again, this is an interannular valve, right? So you're not, being at 1 or 2 doesn't mean you're much higher than that. You're really in the annular plane, which I think makes a huge difference here.
We saw this with Optimize Pro as well, which Amber kind of reflected on. And with these higher implants, with the self-expanding valve with an external wrap, we've seen, I would say some people would call it paradoxically less paravalvular regurgitation. It's because of that wrap's ability to really interdigitate with the leaflet anatomy, versus leaving it down in the LVOT. And so with Navitor, I think we're going to find the same thing, that these higher implants are going to lead to less conduction disturbance rates, probably better hemodynamics, less rates of halt ham, and then obviously less PVL as well.
For sure. Conrad, what do you think of that positioning? Happy? Would you post still, leave it alone? Perfect. Amber?
It looks great. I actually have a question for Hemel. So when you're pacing off the wire, typically when we're happy with the 80% mark, we pull the wire back into the device platform, and we have traditionally a pacemaker in place. How are you guys doing that from your standpoint in terms of pacing if you are pacing off the wire?
Yeah, we just go slow. So that's a good point, Amber. So, I mean, if we notice a conduction disturbance at that point, we can always put the wire back so that there's some LV contact and pace accordingly. As long as you don't have the delivery catheter pulled back too far, that'll insulate just fine and conduct just fine. But our tab release or paddle release is done with the wire pulled back, and it's just slow and deliberate over about 30-second period of time.
Great. This is, Dustin, you want to wrap up with closure?
Yeah, sure. We briefly went over the hemodynamics there, but there's essentially, minimal gradient on this valve, single digit gradient as we see on the self-expanding valves. And this is us with closure on the left side. So we basically are cinching down our per closes with the J-wire in place in case there's a rescue necessary and we need to go with something else. So we'll pull those, we'll pull our 12 French sheath, we'll pull out our wire here, and then this is just immediate hemostasis in the OR. We're still fully anticoagulated at this point. We do tend to give a low dose of protamine at this point, usually 25 or 50 milligrams, and we're trying to reverse to an ACT of less than 150, 160. If we have no bleeding and it's 180, we leave it alone. We'll remove our suture material here, and this guy will be up and ambulating later on in the afternoon. You can see it has quite a deep access there as I'm going down and cutting these knots, which is not a concern with modern devices and these closure techniques. We've gotten pretty savvy with this. On the left-hand side, we'll pull the vein out and hold manual pressure, and on the right side, we will just use a closure device traditionally for the small arterial access site. The other point about the case that was interesting that we sort of glossed over, but I mentioned the STs earlier. We put the Navitor valve in, we felt the STs were still elevated, and in 30 seconds, we're able to easily engage the coronary in this case with a JR4 and show that the right coronary is widely patent. And we do see these ST changes in the setting of patients with pulmonary hypertension and bundles and RV dysfunction from time to time, and that was our conclusion here. But it was nice to have a valve that was very easy to navigate through and see a coronary on our way out. It made us feel a lot better before we got to the PACU and saw the post-op EKG with ST changes. Conduction was intact here, as you saw, based on valve positioning, so we were satisfied with that.
Great. I think just to sum up, Kathleen, you want to just share with us where you think this valve tends to shine and the advantages over the other commercially available platforms?
Yeah, so certainly the hemodynamics are superior to the balloon expanding valve based on our experience and based on what we see already, everywhere else. And as far as relative to the other self-expanding platform that we have, the coronary access is markedly better with this, right? I mean, the cell size in this valve are significantly larger. In fact, if you put a portico inside a portico and misalign them 180 degrees, so perfect misalignment, the cell size are still larger than an Evolut. So you can put two of this, one inside of the other, and achieve the same thing. The other thing is the deliverability is perhaps more deliverable. I mean, it's a newer, later generation delivery platform. And one thing I'm looking forward is to sort out the commissural alignment, which remains a bit of a problem. I think the company is working at ways of doing this. I mean, I really think that's going to be important, especially as we're moving into a younger patient population and doing this in low risk and moderate risk patients in the trial. So.
Great. Hemel, anything to add to that?
No, I think all the comments are dead on, and I think the commissural alignment piece is something that just needs to be figured out with this valve. One valve that we did not talk about really is the Accurate valve, Boston Scientific valve that just completed its Accurate IDE study. So more data with regards to that, and just a whole nother discussion with regards to valve therapies once that comes into the market.
Great, wonderful. We'll wrap up there. We'll just take a 2-minute break, and we will be back on. Thank you so much.